Thank you for the invite to present this mini lecture on a very important topic, which is bone health after hip fracture. In keeping with the instructions, I've tried to summarize the information in 5 key slides, and hopefully this will be useful. At the beginning, it's probably preaching to the converted. But it's worth reiterating the importance of initiating treatment after hip fracture. The important concept of fracture begets fracture. So you have what we call a signal fracture and a sentinel fracture cascade. About 50% of patients presenting with a hip fracture would have experienced a prior fracture. The Glasgow Fracture Liaison Service, which was really the pioneer liaison service in the world, established that 80% of refractures will occur in the first year post the index fracture. And more importantly, 50% of these refractures will occur within the first 6 months for hip fractures and within 8 months for non-hip fractures. This really highlights the importance of starting treatment straight away. This is my summary slide on what I think are the key barriers to osteoporosis treatment initiation after a hip fracture. There may be others, but these I believe are the key ones. And I've divided them into patient-related, the first 3, and medical professional related. So I shall go through them. The first one would be acute and chronic renal impairment with osteodystrophy, which is not uncommon in our frail elderly patients with hip fractures. Second one would be swallowing difficulties or dysphagia for oral medications in the inpatient cohort of hip fracture patients. Delirium on dementia, complicating informed consent and patient education about new osteoporosis medication is also not uncommon and can often be a barrier. And then there are what we call the medical professional related issues, namely the lack of investigations, including baseline calcium and vitamin D status and potential secondary causes of osteoporosis or metabolic bone disorders. This does not exclude the DEXA. Medical concerns about potential side effects of osteoporosis medications, especially if they've already been on bisphosphonates over a prolonged period. Medical skepticism and nihilism about the benefits in frail older patients with comorbidities and limited life expectancy. These are what I think are the facilitators to initiation. What you really need is a clinical champion to facilitate this change of culture, to prioritize health management, bone health management during the hospital stay as critical in the management of what we call an acute bone attack as compared to an acute heart attack or an acute stroke. The second big one is ongoing education of junior staff to routinely initiate investigations early on during the hospital stay, which is often quite short. You do need informed consent, and this can be obtained from the substitute decision maker after osteoporosis education in the ward if the patient is unable to consent. Remember, IV bisphosphonates can be used if appropriate in patients with swallowing difficulties. And subcut antiresorptives like denosumab can be used in renal impairment if appropriate, and you have excluded low bone turnover or a dynamic bone disease. Remember, if you're not comfortable with this, you should seek medical advice if you're unsure, because there may be agents that are appropriate. I've put in a slide here about some of the key concerns about side effects, and the 2 main ones are osteonecrosis of the jaw and a typical femur fracture. If you look at some of the numbers here, ONJ, mainly described in IV bisphosphonates in cancer patients, incidence less than 1 in 10 to 1 in 100,000 patients. Risk of AFF, about 113 per 100,000, especially if you're on a prolonged duration. And remember, individualized treatment decisions would be based on relative numbers needed to treat, numbers needed to harm. Just to give you an idea, put in So if you have a 1% risk of hip fractures in women with postmenopausal osteoporosis, you could expect up to 300 hip fractures for every 10,000 high-risk patients. And assuming an effectiveness of about 36% for bisphosphonates, you can prevent about 108 hip fractures, besides up to 750 at other sites, whereas the possible atypical femur fractures, subtrochanteric fractures, you're talking about 3 to 6. So this gives you an idea of numbers needed to treat and numbers needed to harm, which can help you make that individualized treatment decision. I hope that's useful. And finally, I've got this one slide, which is, of course, the bigger picture. It's not just about initiating a treatment. It is, are you doing the right thing? So what I believe are the barriers to effective osteoporosis management, or what we call the current gaps in treatment strategies. The big one is convincing commissioners about the proven cost effectiveness of fracture liaison service and how we can get ongoing funding. We've had a couple of pilot projects, but ongoing funding is really the issue. Barriers to ongoing treatment adherence. This is again a very big topic, and these could be patient-related, caregiver-related, disease-related, and medication-related. We don't have time to go into these. There are current emerging concepts of what we call a very high fracture risk based on multiple clinical risk factors, and a lot of our hip fracture patients would fall in this very high fracture risk. However, there's relatively modest efficacy of our current antiresorptives. They're quite slow to achieve this benefit, especially for non-vertebral fractures. And there are, of course, PBS limitations to considering use of anabolics early on in therapy. With increased life expectancy, you often need more than one medication and sequential treatment through lifetime. Besides, how do you define, assess, and effectively manage antiresorptive treatment failure? These are some of the gaps we have currently in our treatment strategy. But I shall leave you with that and leave you with this thought. Thank you for your attention.